I just wanted to say thank you so much to everybody for having myself here on this platform and joining for this conversation around diabetes and the connection to heart health, which is very much so a big connection that we need to focus on in the month of February and beyond. So thank you everyone today for listening and for learning more. Next slide. So I just wanted to give a brief snapshot of who we are at the American Diabetes Association, because it really is important to think of who we are, what we do, and why we do what we do. So we really work to prevent and cure diabetes and to improve the lives of all people affected by diabetes. And we do that in a number of different ways, really thinking about building professional education, which Barbara will talk about more later today, thinking about the standards of care specifically that the American Diabetes Association designs and releases on an annual basis to make sure that we're best equipping the community and the diabetes ecosystem to help people manage their diabetes and then work on prevention as well. We're also stepping into the obesity prevention space as well as obesity management with the American Diabetes Association's creation of the obesity organization last year, because they are linked and we want to make sure that we're educating in both lanes of those conversations when we're thinking of dismantling stigma and providing opportunities for access and care in both the diabetes and obesity arena. We really focus on health equity and access through many different areas of opportunity through the program work that we do, but also through the state and federal advocacy work that we do. And we work to connect people in our communities in a number of different ways, which I'll share in a moment. And Ryan, we can go to the next slide. Thank you. And as we're working to be the global leader, the trusted source and preferred partner, we do this through groundbreaking research, being the innovative leader in looking at science to prevent, treat, and ultimately cure diabetes. But in the meantime, we want to make sure we're helping improve the lives of people who are living with diabetes right here and right now. And we do that through really proactive advocacy work and legal support for people who may be facing workplace discrimination, our Safe at School program to make sure that children have the opportunity to thrive with diabetes in their school systems and not be discriminated against and have every opportunity to participate in after-school programs and sport opportunities. We provide programs through trusted education. We provide evidence-based education. We focus this on not only the people living with diabetes and family members, making accessible education in your homes through all of the work that we do at diabetes.org and social media and virtual opportunities for education, as well as in-person programs, but also through educating the professional ecosystem in the diabetes space. So thinking of the folks here on this call who may use our resources through our professional network. And then, of course, we work to provide meaningful connections and provide strong networks, because diabetes, as we know, can be quite an isolating condition. And so we want to provide those community connections for people, whether that be through our programs and education opportunities, networking components, or our events that we'll be talking about a little bit in a moment, thinking about no matter where you live, being able to find a connection through the American Diabetes Association. Next slide. Thank you. And what does that mean here in Massachusetts? The ADA is right here. We may be a national brand, but we really do drill down into the heart of our communities. And you can see here, being from Massachusetts and in New England, there's a lot of activity. We have over $10.5 million worth of research happening in Massachusetts alone, focusing on different areas of needs in diabetes prevention and management, whether that be social determinants of health, food is medicine, and focusing on different heart-related conditions and other really specific areas of diabetes management, making scientific strides in that arena year over year and continuing to make those investments so that we're working towards that cure, as well as improved outcomes for people impacted by diabetes and all of the comorbidities associated with that. We also have a call center here in Massachusetts. We inquire from hundreds of people calling in on an annual basis to be able to identify what their needs may be, where they need the support, and how we can find those resources for them right in their zip code, from food insecurity resources to transportation support, access to diabetes medication, and beyond. We also have professional memberships, diabetes advocates. As you can see here, we have over 8,000, almost 9,000 here in Massachusetts alone, something we're always looking to build. So when there is the opportunity for us to advocate on behalf of those living with diabetes, whether that be through state legislation or beyond, signing up to be an advocate is a great way to participate in that movement and really make an impact here in our community in Massachusetts. Next slide. Thank you. And how can you get involved? Here in Massachusetts, there's a lot of different opportunities for you all to join us, whether it's for yourselves or your patients to find that opportunity for community. I know Michael C. is very familiar with a lot of these events, and I think I saw Callie Roberts on this call as well. A lot of familiar faces who might know some of these programs. But specifically, we have the Tour de Cure, which is our cycling event in August. We have a camp in New Hampshire that we host every summer for a week for children living with type 1. And it really is a really impactful program for not only the children living with diabetes, but the entire family, so that they can have a medically safe environment to enjoy a traditional summer camp experience. We also have a golf tournament, which is new to our community, which helps us connect with people outside of the diabetes industry and the C-suite to really make sure that high-level employers are understanding the impact of diabetes and what that means for their community. The Tour de Cure that I mentioned, and then State of Diabetes, which is going to be in November this year in the Boston area, where we have a panel discussion focused on diabetes management. It's an interactive networking event on top of the panel discussion with breakout sessions this year, as well as some focused healthcare screening opportunities for the community. Next slide. So just thinking about how you can get involved, the two big examples that I'd like to lean into are the Tour de Cure, which is the unique opportunity to ride between 5 and 100 miles, so something for everybody. But really what I want to get across here is that this cycling event is about community, pulling together, raising awareness, but also providing that platform for community celebration in a very accessible way. Unlike other rides, we use this as an opportunity not only to stay active, but to prevent and manage diabetes by getting together on a weekly basis once the snow's off the roads to do training rides and encourage that kind of activity with our teams across the state and throughout New England. It's a $10 registration fee and $250 fundraising minimum. And I share that because we really want to make sure that this ride is accessible to everyone in our community and reflect that of who we serve. So if anyone has any questions on that, please feel free to reach out to me. And I know Michael C. will be out on the roads with us on Sunday, August 17th as well. Next slide. I see you smiling there, Michael. And then I also want to share a little bit more about our State of Diabetes program. This is a panel discussion where we have leading experts and those impacted by diabetes come together on the stage to really shake that tree a little bit further, to think about where we are here and now in the state of diabetes and what we can do to make a tangible impact. This is also an incredible networking opportunity with people who are in the diabetes ecosystem to connect and help ideate how we can further this conversation outside of the room in November. Beyond that, we also host health screenings for free for the community. So thinking about A1C checks, oral health, eye health, we talk about heart health as well. So thinking about all of those complications associated with diabetes, we provide an opportunity for community members to gather and get these free screenings as well as food resources from the community right there in the room, almost like a one-stop shop for diabetes care and management. So we encourage you all to join us. That we'll be launching the registration for that later in March. So we'll share more information there. And I can, of course, drop my email into the chat. If anyone has any questions about these, I'll be here for the Q&A later on. But this is an evolving conversation that I encourage you all to be a part of, and feel free to reach out to me directly if you have any questions. Thank you.
Thank you, Rachel. I got a little ahead of myself because I was so excited, but You want to share that?
Oh, yes. Thank you. I apologize. This is just an additional opportunity to get involved, whether for yourself or other people in your community, to just sign up and you'll just get notified when there's action to take, whether that be showing up to the State House in person or just signing a waiver to encourage activity within our State House. This is that opportunity to do so. So I'll share a link to that later on as well. Thank you,
Thank
Michael.
you. Thank you, Rachel. Why don't we just go back, Ryan? I have a few slides. I can attest, and I will put a link. My team is called Wheels of Freedom. So if you want to bike 5 miles, and this year I've committed to biking the century, the 100 miles. So I'm really excited, and it's words do not do the program justice because it's a sense of community, it's fun, it's challenging, it's exciting, and so much more. It's beautiful too, the courses. So um, continuing ed credits, we do a lot of work to secure CEUs from ADCES across all disciplines, whether you're a CHW, a nurse, a dietitian, whatever, you can get continuing ed credits. So I encourage you to go on, and this will all be sent to you um, after the recording, after the program, how you can secure continuing ed credits. I often read to people like, how do I get continuing ed? They're so expensive. These are free, and we commit to doing this. And it really brings people together, not only from the Commonwealth, but nationally as well. So we'll just go next slide, please. So this is our kind of upcoming schedule. We'll have our next meeting will be in April or May, part of our quarterly programs. The survey will really help us uh, select on topics that are most relevant, most interested to everybody. Upcoming March 8th, Breakthrough T1D, or many of you may know it by JDRF. They have their community summit at Copley Place, a wonderful opportunity to engage with people living with diabetes, also in the diabetes care community. This is a program that our ADCES does. Again, it's free. I'll share the link with you. It's a webinar that we're doing later in March. And then ADCES has its May meeting we're doing at University of Western New England. It's a half-day program. These are very reasonable, continuing ed credits, and opportunity of networking. So next slide, please. How can you resources? Uh, ADA has amazing infographics, handouts, both for people living with diabetes, but also healthcare professionals. Really, a membership is very reasonable, but they also have resources that you can take advantage of. But also, the Massachusetts Health Department has resources. You can get these as PDFs, you can get them as handouts mailed to you, from health screening cards, educational materials. So really take advantage of the resources that Mass DPH has available. Next slide, please. How can you stay up to date with all this? Is join our network. Um, you know, Opportunity for professional networking, know when these types of programs are coming up to earn continuing ed credits. If you want to get more involved in either our program committee or some of our special projects or communications, it's not a heavy lift, but it's so rewarding to work with like-minded people that have, a sense of purpose and meaning. We'll go to the next slide. This is our quarterly newsletter that Julie handles and that our communication committee kind of supports her on. We highlight, people within the Commonwealth that are doing exceptional things in the diabetes space, resources, events, programs, just all the stuff that we had today from ADA and so forth will be on our next newsletter. Comes out every couple months. And next slide. And so if you do have questions, Jen Braz is kind of our fearless leader at Mass DPH. I'm just one of three people, co-chairs. You'll get to meet them, our other co-chairs, both in our programming and our leadership in future, because I'm going to pass the baton to them for future programs. But these are the contact information if you want to get involved, if you have questions, or if you have information you want to share. Maybe you're doing some exciting work in your part of the state, or maybe you're from another state and you're saying, we're doing some really exciting stuff in diabetes and we want to share it, or we want to learn from you. So it's bi-directional. Next slide, please. And I am going to end there, and we're going to, I shared with you our first speaker is going to be recorded, Barbara, on the 2025 standards. And then we'll go into our second speaker, and then we'll have time for question and answer. So we'll let them cue that up.
Yeah, just a quick point of clarification too. We actually were not able to obtain CHW CEUs for this particular learning session because we have to go through a different process to get those. But we will keep trying for future learning sessions, but all the other CEUs should be all set.
Sorry about that. And sometimes if you have something you can apply, you share the objectives, and sometimes they may kind of honor that, but I can't assure you of that.
Thank you for joining us today. My name is Barbara Eichhorst. I'm a certified diabetes care and education specialist. And today we're here to talk about standards of care for 2025 and how you can integrate them into your practice. I have no disclosures. So we're going to start with what's new in standards of care for management of diabetes. We're going to strategize on integrating those standards of care into practice. And in the end, I'm going to share nice resources with you that you can use with people with diabetes and yourself to further your knowledge about diabetes and a different way into integrating it into practice. What are standards of care? So standards of care are intended to provide clinicians, patients, researchers, payers, and other interested individuals in the components of diabetes care. It also addresses general treatment goals and provides you with tools to evaluate the quality of care that you are providing for people with diabetes. There are 17 different sections in standards of care. And I'm not going to talk about all of them. I'm just going to highlight things to you that you as a diabetes care and education specialist in any form, you'll be able to possibly use in your practice, and it has relevance to what you do. What's new about, I think that it's probably the biggest news that came out recently, is now we have a way to screen for type 1 diabetes with antibody-based screening, especially for people with pre-symptomatic type 1 diabetes. So you can, if you're interested in it, you can look into it because it discusses different tests that are needed and what blood glucose levels are diagnostic for type 1 diabetes, and additional support information that you'll be able to utilize. With Section 3, there is information added about sleep and diabetes. Sleep is connected to diabetes. We now know that sleep is important as physical activity or eating patterns. It's part of our lifestyle, self-management of diabetes. There is information added about bone health and how it can be negatively impacted by medication that we take, like TZDs and sulfonylureas, and it is recommended to screen for any bone health issues. Section 4 discusses dental care. So people with diabetes should be referred to dental exam at least once per year. And this is not new, but it is highlighted because we know that there is a very close connection to dental health and diabetes. So we are in a position to help to coordinate efforts between the medical and dental teams to appropriately adjust glucose lowering medications and treatment plans prior to and in a post-dental procedure period as needed. Disability also is being addressed, but we want to assess for disability at the initial visit and therefore the decline in the function at each subsequent visit in people with diabetes. And people with diabetes should be referred to an appropriate care professional specializing in that specific disability. There's information added about sexual health for men and information added about sexual health for women, especially linking it to the urinary tract infections. There's a lot of news in the field of liver disease. Now we have new terminology with naming liver condition, so please look it up. For us, for diabetes care and education specialists, what's relevant is liver health as part of our lifestyle management strategy. So you can help people with liver conditions to integrate healthy lifestyle into their daily routine. We also recommend weight loss for individuals who are obese or living with obesity or overweight to help with liver health. We recommend optimal diabetes management, of course, cardiovascular risk reduction, and need for metabolic surgery if recommended for that individual. But liver health is really extended, related to obesity treatment, a pharmacological intervention, and the new terminology that is indicated for describing liver conditions. With medical nutrition therapy, there is nothing in particularly new, but I do want to highlight eating patterns. We know that there is 7 eating patterns that are there with evidence base, and those eating patterns show improvement in a clinical care. And then I'm going to talk to you about which specific clinical care outcomes are applicable to each eating pattern. But we do want to use eating patterns. There's no more any diet with specific components of carbohydrates or percentage of fat or protein in it. It's more of an overall eating pattern that is part of the healthy lifestyle that is recommended for people with diabetes and pre-diabetes. So we know that there is no one eating pattern that fits all. From the consensus statement from 2019, we are working on a new consensus statement, nutritional consensus statement that is going to be available in 2025. But meanwhile, the evidence that is in existence and a paper that we use for reference is a nutrition therapy for adults with diabetes or pre-diabetes, which is a consensus statement. So the best outcomes are always coming from the way that we individualize the intervention and diabetes and nutrition strategies for people with diabetes. And as I mentioned, there is no specific calories from carbohydrates, protein, and fat as part of the eating patterns. It's more of a how we eat, what food do we choose as a healthy eating pattern or eating style. And we know that one single recommended nutrition plan for everyone, it isn't one. It just doesn't exist. Everybody is different, and our nutrition food intake is impacted by our environment, community, cultural food preferences, and a lot of different factors that we cannot just make people eat one specific way. I am also bringing up to your attention, comes from the same paper that I just shared with you, which is a consensus statement, different evidence for those eating patterns. I like this table because you can use it with people with diabetes and pre-diabetes to make a decision in terms of what eating pattern they fit best in, and then we can start from there. But you can see that there is 7 eating patterns: Mediterranean, vegan, vegetarian, low fat, very low fat, low carbohydrate, very low carbohydrate, DASH, and paleo. But paleo, there is inconclusive evidence, so there's typically 7, 8 minus 1, which is paleo. But I like this table because it tells you, like, for example, a Mediterranean has impact on low A1C, can positively impact lower triglycerides, can lower cardiovascular risk, and lower weight as well. And as far as you can see, the cardiovascular risk, the evidence stays the Mediterranean is the one that can do that. A lot of people are eating within that style. We also know that there is to lower LDA, there's evidence that vegetarian or vegan nutrition pattern can lower it, and with the blood pressure, very low fat, low carbohydrate, very low carbohydrate, and DASH can also lower the blood pressure. And this is the existing evidence that comes from 2019 consensus statement. When we have the consensus statement in 2025, this specific evidence might change and can be impacted by the more recent evidence. But we no longer call it a diet, because diet suggests that this is something temporary for the goal of weight loss. We call it eating pattern because it suggests that it's a holistic approach to overall healthy eating. I'm also very excited about more inclusion about fasting. And then we added, not this year, but starting last year, we added a religious fasting component to the section 5. And this one is one of the illustrations showing the difference between a religious fasting versus intermittent fasting. And you can see that the risks of possible hypoglycemia can be present at both of them. The overall difference between religious fasting, and particularly Ramadan, that is soon to come, is that there is no water throughout the whole day of doing the fasting. So it's a fixed duration and timing. It's always every day, very similar time of the fasting. We also have the high level of intrinsic motivation for the religious fasting. Of course, the risk of hyperglycemia and the fasting hours with or without ketoacidosis. And then we have a dehydration is possible in some types of fasting. And intermittent fasting is different hours. And there is typically no need, no added risk of dehydration because people are able to drink during the time of the fasting. And hyperglycemia is unlikely as it's not related to the specific overeating. Physical activity, we have an indication to counsel youth and type 1 diabetes or type 2 diabetes to engage in 60 minutes per day or more of moderate or vigorous intensity aerobic activity with muscle strengthening and bone strengthening activities at least 3 times per week. And remember, there is a big issue about the bone in terms of bone health. So physical activity also relates to the bone health, in addition to, of course, other things. There is a section about smoking cessation, tobacco, e-cigarettes, and cannabis. And then there is more information on it, particularly for people with type 1 diabetes, because it can be linked to a diabetic ketoacidosis. Section 5 is supporting positive health behaviors, and that includes diabetes self-management, education, and support. The medical nutrition therapy is in it, physical activity is in it. but we also have behavioral strategies in there, and behavioral strategies should be used to support diabetes self-management and engagement in health behaviors to promote optimal health-related quality of life and health outcomes. Very strong statement. Section 6, we do want to screen individuals at high risk for hypoglycemia. And we know that now we have a new categories for hypoglycemia, so you can look into it, class 1, 2, and 3. And I like this visual. There's many other nice visuals that you can use to guide the practice, but this kind of addresses the treatment goals with glycemic management for different people who are younger, older, and also we are looking for more stringent goals versus less stringent goals to define the treatment. With technology, what's very exciting is the continuous glucose monitors these days and other technologies that help people with diabetes to manage their condition. And the recommendation is to start early, especially with the continuous glucose monitors. They can be started at diagnosis in some cases. We also have this specific algorithm that many of you have been familiar with, and this is typically updated. No major changes since last year, but the reason that I'm highlighting it is because anywhere you look, there is always healthy lifestyle behaviors that includes diabetes self-management, education and support, and social detriments of health. And that is a link to the minimization of the therapeutic inertia. The more we are able to work with a diabetes care and education specialist, the better it is. And I always tell everybody that diabetes education is like a very good pill. It only works when you take it. So the key is to have access to a diabetes care education specialist and then work with that individual on an ongoing basis. Diabetes changes, as we all know, that there is 4 times to see a diabetes care education specialist, and then with different comorbidities, with different changes in people's lives, it is important to come back to the foundation of working or partnering with diabetes care education specialists throughout the cycle of living with diabetes to best manage the condition. There's also a very nice statement about the use of a compound GLP-1. We produce a separate statement, but also integrated that parts of that statement into the standards of care. So the compounds, compounded products that are not approved but by FDA are not recommended due to uncertainty about their content that can produce a questionable safety, quality, and effectiveness. And many of your patients, I'm sure, are right now faced with the reality of very expensive GLP-1s, and some of them are on the compound GLP-1s. So just if you are interested, you can read more about that. This is related to the cardiovascular risk factors, where you see that reduction in diabetes complication happens with ABCs, glycemic management, blood pressure management, lipid management, and agents with cardiovascular and kidney benefits. So diabetes is now, as you all know, cardiovascular and also a renal condition with a lot of possible complications. So we're looking at it from a holistic perspective, and the lifestyle modification and diabetes education is always a foundation of it all. This is another great algorithm that I want to showcase with you when it comes to screening for coronary artery disease, heart failure, and then PAD as well. Additional one with the related to cardiovascular risk management, where we are looking at the lifestyle of healthy eating, physical activity, smoking cessation, weight management to minimize the risk factors. But I like the way that this is organized so you can easily go in and then outline the treatment algorithm. This is also a very nice visual. I have used it in my own practice. I most recently have worked with older adults with diabetes, so this is very close to my heart, and it was an everyday reality of complexity of diabetes management with older adults, who many of them do not effectively recognize the symptoms of hypo or hyperglycemia. The body kind of does not give them the same symptoms when are given to younger adults. So this is, I have used it into practice a lot when we talk about the mentation, medication taking, mobility, and what matters most to older adults with diabetes. So for those of you who are working with older adults, you can use this specific indication. But I can tell you from my experience, I have seen a lot of falls that are unintentional and often linked to the hypoglycemia, because some people are still on older classes of medications that are causing the hypoglycemia. So be aware that this the hypoglycemia in older adults is linked to a lot of acute and long-term side effects, including cognition. Additional nice algorithm that I want to showcase for you that you can kind of use when it's needed. So now I want to kind of cross over to a person with diabetes and showcase to you the different resources that we have at American Diabetes Association that you can use for people with diabetes and pre-diabetes. So what we have is actually patient standards of care, which is really cool and unique, because every year we have these beautiful healthcare professional standards of care, where we guide healthcare professionals with the information and strategies to be able to integrate into their corresponding practices. But how about people with diabetes? So what we are doing is we are taking the standards of care and then for healthcare professionals, and then designing it so it's the same consistent message for people with diabetes. So this way, whatever we communicate to healthcare professionals, the content is being consistent what we communicate to people with diabetes. Even better for you, diabetes care education specialists, you'll be able to use those, and then it will allow the person with diabetes to be more empowered with information, so that when they're going to go to their physician or provider, they'll be able to say, I have learned this with my diabetes educator, and I would like to learn more about kidney. What do I do with kidney health? Like, what do I do with bone health, and so on. So this is going to be fantastic. Electronic version is going to be arriving in 2025. And print, it's already 2025, in June 2025, and print version is going to be available in July. So the electronic is going to be at the scientific sessions, it's going to be launched in scientific sessions, and print version would be available right after scientific sessions. What we have also done, and especially for those of you who are part of our education recognition programs that's within the ERP university, we have organized it into all of the patient education materials and whatever you need for your own education, continuing education with ADA. We have organize it into the 9 content areas. And the reason for that is when you have the education recognition program with American Diabetes Association, we have 9 content areas that that could be utilized for diabetes self-management education and support. I came also from DSMES, and then it was always very hard for me to find things because it was confusing, that there is 9 content areas and which one belongs where. So I needed to organize my own handouts and the resources, and many of you do the same thing. So this will help, because then whenever you go to ADA to print out patient education materials, or you want to get your own continuing education with specific topic area, it will be easier to find it. So we have it organized as diabetes pathophysiology, how diabetes works and how obesity works, how kidney disease works, the biology of living with specific medical condition. We also have healthy eating, being active, taking medications, acute complications, monitoring blood glucose, chronic complications, lifestyle and healthy coping, and diabetes distress and support. So I welcome you to view it and use any of those resources. They're all for free, and you can download them or use it for a continuing education if you would like. We also have still looking at the effective name, but it's going to be called Diabetes Care Roadmap, a guide for people with diabetes and healthcare professionals, and it's going to align with the 5 elements of the intervention that is going to be related to prevention, diagnosis and assessment, treatment, preventing and managing complications, as well as diabetes technology. I'm very excited about this as well, because this one is the better searchable way right now to find your resources, where I mentioned to you those standards of care for people with diabetes and pre-diabetes. There's also different resources that you can find it much easier than it used to be. The searchable data is better organized and then categorized with those 9 topic areas. So the patient education library is also there, and is also updated and easier to search and find the information on. So a newly added feature is that better search data. Also, what we have is another way to help you with people with diabetes is we have a consumer guide. Many of you probably remember when we used to get the magazine that was coming, I think it was Diabetes Management, maybe Self-Management. It was meant for people with diabetes, but many of us, such as myself, healthcare professionals, I was using it because in every January it was coming out with a nice, different products, different pumps, different blood glucose meters, different strips, whatever related to technology and diabetes management. It was in there. And now we have electronic version of it, and it already exists. But what we're doing differently, we are completely revamping the user experience. So it's very similar to the original, where you can compare 5 or 6 products, and we can compare 5 or 6 CGMs, or blood glucose meters, or insulin pens, or medications, and it will give you the description of comparison to it. So it's just a better user experience of the consumer guide, technology decision, different technology, and then you can make the decisions with the person with diabetes. So this is what it's going to look like. This is the landing page. So right now it's there, but it's not categorized as easily as we would like to be. So watch out, within the next few months, you'll be able to save it and print as a PDF, so you can give it to the patients with corresponding products that are applicable to them. And you can also use it to help people with diabetes to make the decision about which product to use for what reason. So we're going to have the treatment, we're going to have tools, and we're going to have a technology in there. So this concludes my presentation. I thank you for joining me today, and I welcome you to visit American Diabetes Association for those resources. All of these are free of charge, so you're able to utilize them to your liking. Thank you for your attention, and I'm looking forward to your questions.
Hello, am I going next?
You are all set, Buba. Thank you.
Thank you very much. I'll just put myself on presenter mode. What I did it earlier. So, okay. I don't know if everybody can see this. Okay. Can everybody see this? Do you also see my notes or not?
You had, we
Your
can see
notes,
your
yes.
notes, Buba.
Yeah,
You
Booba,
had
the
it.
first time you shared, we didn't see your notes, but now we
Perfect.
do. Yeah.
So this one is better? I'll
Yep.
do without
Yes,
my notes.
this is just the slide. Yeah.
Yes.
Thank you. So hi, my name is Buba. As Michael introduced earlier, I'm also a heart patient, and then would turn kind of, I would say, a social entrepreneur. So I was diagnosed in 2012 with cardiomyopathy. So they just told me my heart was bigger than normal. So when they told me that, I was kind of laughing, and I was asking why they're saying, what's a big heart? So in my case, I was thinking it was just a compliment or something. So fast forward, they told me that my heart is bigger than normal because I've had, my heart wasn't pumping normally, but it was also too big. And that's where the nickname Heart of a Giant came from. So this was, let's say, 12 years ago, 13 years ago. I managed it for about 4 years, up to 2016. But then I had a long trip to California. At this time, I was living in Senegal. So I moved to traveled to California and was diagnosed. Basically, they told me they confirmed the diagnosis, but they told me that I was at end stage heart failure. So and I needed a heart transplant. So at that point, we decided to move to Boston, where my wife is from, and then I live with an AICD just to make sure my irregular heartbeats were under control. And then I was implanted what they call LVAD, the left ventricular assist device, which helped my heart beat for about 6 years while I waited for the heart transplant. So as of 2 years ago, a little over 2 years, I got my transplant, and I've been doing very well since. So that's kind of on my health side, but we've been able to continue normal life. My wife and I, and we when I was initially diagnosed, we had our firstborn, and then soon after my LVAD, maybe a year after my LVAD, we became parents again. So we have 3 little boys, and we live in Boston, and they're keeping us busy. So out of the journey, I was just always asked questions about my condition and updates. So started blogging, and that kind of moved on to fundraising for the counterpart of the ADA, so American Heart Association. So did a lot of fundraising for them, and eventually I decided we'll start an organization to basically support heart health, but specifically in communities that are not so well served. I've been very fortunate, but I did notice a lot of gaps in terms of just almost everybody really basic understanding of certain conditions or heart disease, or actually the links between them. So we decided to start an organization that will kind of support that. And we'll do that through a few things. So since 2000, I think I launched that in 2019. And then we've been doing a number of things to be as comprehensive as possible. So first thing we really do is to raise awareness through different platforms, and so in campaigns, webpage, and things like that. We do a lot of workshops for education, and we have other outreach programs. The part we're really excited about is we call it screening, but it's actually merging screening and education. So we have one-on-one conversation with at events, or we have regular partner locations where we go regularly. And then as of recently, we've been doing remote patient monitoring and also continuous monitoring. So really supporting the patient through the journey of and getting the numbers under control. So it could be blood pressure, it could be diabetes. Those have been our main focus, but we soon moving to other areas, like whether it's cholesterol or weight loss and areas like that. But the idea is that we want to support them in between the doctor's visits. And then also we want to also support not only the patient, but the larger community, so the caregivers and other people in the community. So we do that. I think two main things I want to mention there is that we partner with local healthcare organizations, including health centers. We also work with community development centers like the ABCD. We work with senior centers, and our initial base was Dorchester, Mattapan, and Montserrat. Sorry, uh, Dorchester, Mattapan, and Roxbury. But we've been as far as Bridgewater, dealing with the students there. We've been at in East Boston, and we've done Cambridge, Brookline, many other areas in the greater Boston, also Brockton. So just have some highlights in our numbers as we go. Last year was, I guess, our biggest year as we've been growing steadily. But we've done like screening around with the people. So these are people we've seen more than twice at events, and then they've been and we've been able to kind of see how they improve or didn't improve over the year. So we have those numbers that we shared as we go. So some statistics, I think, sorry, my previous speaker, I think Baba and Rachel talked about this, but we have, in our case, we kind of confirmed what's already known in a way, but probably not to the people that were diagnosed. But we've had a third of our people that we screened were already at stage 2 hypertension. And then there was small percent, well, a 2% group of the group that were already in hypertensive crisis. Those ones were, we kind of treated them as urgency. So we really either send them directly to the clinic, refer them directly to the clinic, or encourage them to get onto an ambulance in some of those cases. And then we've also, through some of the conversation, we kind of seen some links between the sugar levels and then like weight or obesity in those cases. And a lot of these things are also informed by trusted resources already. So whether it's the CDC or the AHA, we kind of been using their material to translate into the community. So translate meaning we'll put them in lower reading levels, so 5th grade or 3rd grade, depending on the situation, or maybe just make them more concise with a referral to the larger resource. The other thing we've done is to translate in different languages, Spanish, Creole, Haitian Creole, Cabo Verdean Creole, Vietnamese, Somali, and of course we have English. So those are our languages. But in addition to that, I think Michael showed some resources through the clearinghouse of the Department of Public Health. So we leverage that a lot. We have strong collaboration with the department where we get those resources shipped to us, I think almost every quarterly, and they cover every topic, and there's almost all the languages. So we that's been very helpful to us as well, and we leverage that a lot. So some of the issues we've noticed really, it's been really I think access to healthcare facilities, not only the presence of healthcare facilities, but having the physical time to go there. So a lot of our people in our communities, or most of us, work like full time. So after hours might not be the easiest. Weekends might be the easiest for some people. So if it's not an emergency, so really there's no time to interact with the healthcare facilities, except for when we're sick. We've been encouraging regular check-ins and follow-ups. But also we've been taking advantage of especially in the summer times, of those larger events to really interact with people and talk to them. And we also, in terms of the lack of knowledge, is also accessibility. So depending on who tells the story, the message really makes a big difference. So we have on our team, we have people from all the different backgrounds, at least for the communities we serve. But we also have trained nurses, retired folks that were nurse managers. We have, and I like the link that was made between oral health and diabetes, but the same thing with heart disease. So we have an oral hygienist in the group. We have a psychiatrist, a pharmacist. So all of those will really help us have a global view, but also help us kind of cover the first steps in terms of the referral process. So when they go back to their doctors or go to a referral, they already have some notes, and we always be there to continue with them. But we've seen that 40% really have in Boston have well 40% have 40% people have 40% higher prevalence, but from our reports, the neighborhoods that were really highest were Mattapan and East Boston. But I must also say that those were also the places that we are more active. So I don't know if there's a correlation, but we've just been really doing that, kind of noticing that that numbers. I already talked about our approach, but I wanted to just kind of touch base on highlight some of the impact we've been able to have. We've been able to really support over more than about 1.5 people in our to reduce their blood pressure. So whether they move from a crisis level to lower or elevated to having in a normal range. So we kind of use that as our guidelines. In many cases, also we've been dealing with people dealing. I want to make sure. Yeah. So I'll come back to the next thing I wanted to say, but so we do that through. We do I mentioned we do like a lot of the education, but we also the awareness. So last year we've been able to really reach over 1,500 people in total. But then half of that were people that were screened. We also try to quantify it in terms of the amount of savings that is made, whether in terms of burden in the healthcare system, to really highlight to the patients, to the potential families, but also in a broader space of the importance of prevention, but also management. But we can, based on like algorithm or data available, we can be sure that this kind of based on some of the events we've done, we've been able to save close to $500,000 in terms of costs associated with stroke or hospitalization. So this model, I think, close to the community is something we encourage. We're developing it and we're hoping to share with other people. But as I mentioned, we not only support patients, but the families get involved, or we take the family into account. So in our programs, our initial goal was blood pressure. Because that's kind of one of the, I guess, lowering it through, but also the most common link to heart disease, and also it's not known, so you can only kind of manage or control what you can measure. So we really been developing that habit of measuring their own blood pressure, but also measuring it for them. In the early days, I used to give away blood pressure machines, but we kind of slowed down on that a little bit. But we do give guarantees for that. Lifestyle changes have been in almost every conversation, depending on how they do it. And also we touch on adherence, touching on some misconceptions. For instance, he was actually a chef. He decided he's gonna stop taking his medication. I'm sure this is something many of you have heard before. But just because his numbers were good, but he felt like he was eating the right things, which my nurse just jumped on it. It was like, please don't do that. Just keep taking your medications and connect with your provider. But just navigating the healthcare system, whether as a patient or as a family, is a challenge. So we've been helping folks learn how to advocate for themselves, especially folks, the elders that have English as a second language, being able to use an interpret, not necessarily a clinical, I guess, interpreter, not necessarily family or young children that don't necessarily have the vocabulary, but also even the interpreter, make sure they have they're doing the right, they're doing what they're supposed to do. So really helping them advocate for themselves, and the same goes for caregivers. For a number of participants, I think over 50, we had 2 locations where we started. We did have them track their blood pressure. And then I think, more than two-thirds of them have been able to have the blood pressure, the blood sugar level under control. We've had some extreme cases too, where even more younger folks, I think it's probably in his 40s, where he was showing numbers of 300 glucose level, and our nurses worked with him over, I think, 6 weeks or so to get it at least within the range of 100. But the main really factor was the awareness. Like he didn't know what was happening or what was causing those. He didn't actually know he had a high blood blood sugar level, but also didn't know it was at risk, didn't know the implication. So the conversation with our providers help him take control and take ownership, and then we've been able to really see some good results. We also, as we deal with the blood pressure, we also help people in the journey of weight loss, which I guess all works in hand, so all the organs are affected. But the blood pressure, the link between blood pressure and other elements, whether it's the weight, water intake, the food we eat, those are information we really keep repeating. But also we talked about also the mental stress level, sense of belonging, and really just living day to day. So we really continuously do this. One of our goals is to really have this model replicated by other centers. So I would say healthcare organizations, whether it's community-based organizations or even faith-based organizations. But we want to continuously call on healthcare partners or providers to partner with them to have screening at let's say partner locations, but also have providers maybe have sent referral partnerships and more patient education resources. And we want to continue to do that. It's something we've seen to help, but we know that none of this can be done in isolation. So communities will really just been our main element, and we want to continue to do that. So it's a pleasure to share what we've been doing in a short period. But we very early on I understood that heart disease and diabetes are very common challenge in our community. But with all the work that's been happening, you've seen some of my predecessors highlight great work happening. But together we can make sure that this information is given to the right folks, to all of us, and we've been able to adopt the changes we have to, but also be ready in case there's a diagnosis or there's I guess there's a crisis. We'll be able to hit it head on instead of finding it out after the fact. So those are kind of some words I would like to share, but I'm happy to take on any questions later. I know I spoke a bit fast, but thank you for this time.